Testicular torsion or torsion of the spermatic cord. It is a cessation of blood supply to the testes due to twisting of the spermatic cord, and this is a medical emergency that needs to be recognized before the cardiac signs and symptoms are fully manifest, as prompt surgery saves the testes. The delay in treatment could result in testicular atrophy, um, abnormal sperm count leading to infertility or sterility, and can be classified into intravaginal torsion, which constitutes more than 95%, or extravaginal torsion, which is usually found in infants. About 50% of torsion occurs during sleep and early in the morning, and it's rare in older children and adults, but common in children under 15 years. The causes are undescended testes, bell clapper malformation, horizontal lie of testes or inversion of testes, long mesoculum or mesoculum, and also trauma, spasm of cremaster muscles. The symptoms are sudden onset of acute severe pain in one testicle or recurrent pain which resolves spontaneously, as recurrent torsion and distortion. The pain may occur typically early in the morning, and lower abdominal pain on one side, nausea and vomiting, no urinary symptoms, no fever. The signs that are usually elicited are swelling tender and abdominal position of testes and epididymis, shortened and twisted cord, edema or reddening of scrotal wall, right testis twisted clockwise, left testis twisted anticlockwise. Friend's sign is absent. That's elevation of scrotum in the palm towards the pubic symphysis, does not relieve pain. And distinguishing between torsion and epididymochitis. At the parameter, let's look at age. So torsion is usually less than 15 years. Epididymochitis is usually more than 15 years, or those sexually active. Let's look at the next parameter. Onset of pain. Torsion is sudden or early in the morning. Epididymochitis is gradual. History of coitus, usually absent for torsion, usually present for epididymochitis. Fever for torsion is absent, but for epididymochitis is present. Urinary symptoms is absent for torsion, but present for epididymochitis. And for urinary urethral discharge is absent for torsion, but present in STIs in epididymochitis. And the position of testis torsion is changed, but in epididymochitis is unchanged. And the next parameter, that's swelling. For the torsion, it occurs in the testis, but epididymochitis, it occurs in both epididymis and testis. Friend's sign is absent or negative in torsion, but present or positive in epididymochitis. For blood supply, that's Doppler test, is reduced in torsion but normal or increased in epididymochitis. The treatment for torsion is surgical, but for epididymochitis is non-surgical. Investigations: urinalysis, FBC, Doppler stethoscope, color Doppler ultrasound scan, 99 MTC, technitate scintillation scan. It's usually 90 to 100% accurate. The main treatment objectives are to have surgical intervention within 6 hours of onset, to surgically explore all doubtful cases, to prevent testicular loss. Non-pharmacological treatment, emergency surgery is a standard treatment. If surgery is delayed, then manual detorsion may be carried out carefully to prevent loss of testes. Manual detorsion procedure under local anesthesia, and standing at the foot of bed untwisted could be done. So right testis anti-clockwise and left testis clockwise. Emergency surgery should follow this procedure as soon as possible. Pharmacological treatment: lignocaine 1% into the spermatic cord on both sides for cord block anesthesia as 10 to 20 milliliters. Referral criteria: refer as soon as possible if surgical intervention is not available to a surgeon, or refer to a urologist. So beware, testicular torsion has potential medical legal implications.